Thank you, Jeff. Good morning, everybody, and thank you all for being here. We're really excited about this workshop. I remember 10 or 12 years ago sitting at one of our first meetings when this all came out, and Meween Curry, is he here? He's not here. I can't even make fun of him, right now. Kind of having heart palpitations because of what was going on with direct-to-consumer testing. And we've come a long way in the time that this has been first introduced to us. And I think this was a little unexpected, actually, that we were going to be tackling this topic. This came out of a workshop that we did in June of 2018 that was on disparities, health disparities, and health inequities. And one of the things that we have been looking at is access to genetic services in general and genetic testing in general. And we had looked at it from the angle of a public health perspective. We had looked at it from the angle of a health system perspective, also the intersection between public health and healthcare systems. And then this kind of seemed like another area that people were obviously getting testing outside of either public health or the healthcare system. And the idea that, and this has been talked a lot about, is that this could potentially increase access to underserved populations, and this has been something that companies have been discussing. And so this made us think about whether or not, what is the current landscape right now of consumer genomics, and is it really penetrating into more underserved populations? And so this is what kind of stimulated the discussion around this workshop and a lot of interest in just learning what the current landscape is. So that's where we started. And basically, I guess that's what I just said right now. We really wanted to look at the current landscape of direct-to-consumer and consumer-driven genomics. We wanted to explore how companies are reaching diverse populations or underserved populations, and if there's any opportunity here to actually decrease the inequities or disparities. And then also, one of the things that we really like to do at the end of our roundtables is think about what action we can take. So rather than sitting here all day and discussing what we think and what we know, but really thinking about what next steps might be, and think about the downstream challenges and actionable next steps for improving integration with clinical care. I want to acknowledge that there was a group of individuals who have been working on this workshop, and they're all listed here, and especially acknowledge our wonderful national or Academy staff, Sarah, Meredith, Shaban, and Michael, and all the work that they do for us. We could definitely not pull this together without them, so I want to thank them for all that. But we did try to pull together a pretty diverse group of individuals with different viewpoints on consumer genomics. One thing we wanted to be aware of is that there's a lot of bias with this topic, a lot of strong feelings that it evokes, whether positive or negative. And so we wanted to make sure that our planning committee represented a pretty wide group of opinions. And we had a discussion at the beginning of our planning that openly acknowledged some of the biases that we had and what we're bringing to the table and how we can manage those while we were actually going through the workshop. And with that, I'm going to turn over to Greg.
Well, thank you, and thank you all for coming today. And I hope none of you had to fly in from Colorado. Looking at the pictures this morning, Denver would not have been the greatest place to fly out of. So that introduction from Jeff and Kathy is essentially all that needs to be said, I think, in the kickoff of this. But there's a couple of points that I think might be made. First, Jeff already mentioned that a large number of individuals have had some form of direct-to-consumer genetic testing, and a very interesting thing to think about, and one of the things that spurred us to think that this might be a really good time to tackle the topic 10 years on from sort of the inception of this area, is the fact that if you exclude newborn screening, it's quite possible that more people have had some form of genetic testing outside of the traditional healthcare model than within healthcare. And that's kind of a remarkable thought, and coming to grips with what that means for health systems and individual health as well as population health, I think is important moving forward. This area is much to the chagrin of some folks that were early naysayers, not going anywhere. I think it's evolved, it has matured, and has meaningful content for health at this point in time, and will have increasingly large amounts of meaningful content. And we need to figure out how to integrate that into health systems in order to achieve the best outcomes for patients. I would say that the other point I would make is Just as a marker of penetration of DTC, I practice in rural central Maine, a very underserved area. I'm finally having patients coming in to ask me about DTC and whether or not they might avail themselves of some of the mail order services to learn more about their health. I have also had, unfortunately, in the recent past, one patient who was approached by one of the companies that was indicted recently for trying to scam folks with genetic testing, and she was literally hounded as an elderly person for 3 weeks on the phone by this company trying to get her to sign up. Now, those are the bad apples. We won't spend much time on that today, but I think there are really interesting dimensions to this that need to be considered over time. So today's focus will be largely on health-related information, not so much ancestry, although ancestry will probably percolate through the day as it may be a driver for consumer uptake for some of the health-related services, but the predominant focus of the day will be on health-related information coming from DTC testing. The issue of reaching the underserved, I think, is a critical one. So I think there's a fundamental assumption underneath that statement is first that we believe the information is medically actionable and useful. If it's not, which we might or might not accept, then reaching the underserved could be a net harm. If it is useful, it may offer a way of leapfrogging around some of the barriers we have in our healthcare system for those individuals who are very far away from any sort of genetic services to access state-of-the-art genetic testing. And so I think the day leaves open room for the debate about utility as well as the issue of narrowing potential disparities. The second half of our day will really tackle the topic of integration, making some assumptions about the utility of the information. How do we move forward in terms of making sure that information gets into the healthcare stream in a way that patients benefit? At the last session, session 5, what we hope to do is to distill the day's conversation into sort of 2 large bins. What are some of the overarching issues that face biomedicine in general in this field? And then what are some of the issues that this roundtable may be particularly able to move forward? So the roundtable views, I think, at least at the level of the implementation work group and leadership of the roundtable, that this meeting is perhaps a starting off point from some more in-depth looks at subtopics. Many of the things we'll be talking about today, each session could be a 2-day event. So this is really a jumping off point. And that I think is probably the most important work product, if you will, from session 5 and all of your input during the course of the day. So moving forward, webcast today. So if you're going to ask a question, please absolutely do. Provoke us, make us think, stand up, give your name at the microphone so that everyone can know who you are, where you're coming from, and also can hear your questions. If you are someone who is viewing us on the webcast, there is a web address there that you can send questions to, and there will be opportunity for questions coming from outside of this room to be answered. And everyone who is on the planning committee and all the speakers, please remember that at noontime to grab your lunch quickly and migrate to room 101. It's up there. I didn't know which room it was. Room 101 for a sort of midday retrimming of the sails, if you will, for the rest of the day. So with that, I think I'd like to introduce our keynote speaker. So to kick off today, we have Dr. Robert Nussbaum. Bob is a person who probably doesn't need much introduction to this group, but he finished medical school at the Harvard MIT HST training program, completed an internal medicine residency at the Barnes Jewish Hospital, and then a medical genetics fellowship at Baylor. And from there, went on to do some truly remarkable things over the years, including helping to elucidate the underpinnings of genetics forms of Parkinson's disease. I intersected first with Bob at NHGRI, where he was a branch chief, and since that time he's gone on to become a full professor at UCSF and now serves as the chief medical officer for Invitae. Really a remarkable sort of scope of perspectives from a variety of different areas in biomedicine, industry, academia, practice, and I think Bob will provide you with a really excellent overview of this area as it's evolved over the last decade. Bob?